The next talk will be by Professor NAMRATA SHARMA, and she'll be covering the topic what Praveen was talking about in this, of doing microkeratome-assisted anterior lamellar keratoplasty, and she will also touch upon the role of intraoperative OCT in performing lamellar keratoplasty. Professor NAMRATA SHARMA, please.
Thank you, Rajesh. Thank you for this wonderful course, and thank you for making me a part of it. So I would be talking to you about microkeratome-assisted anterior lamellar keratoplasty, and there are no financial or proprietary interests. Now, depending upon what level your opacity is, the microkeratome can be used. Praveen has very nicely covered the superficial automated lamellar keratoplasty, which is the SALC. But if the opacity is deeper, then you have to do what is called as automated lamellar therapeutic keratoplasty, or ALTK. And sometimes it happens so that you are able to dissect the donor cornea with the help of the microkeratome, but you are not able to dissect the recipient cornea because of irregularity, and then we call it HALC. So sorry for that error. It is hemi-automated lamellar keratoplasty. Of course, the advantages of ALTK or SALC are there. There's hardly any graft rejection. It is extraocular. There's less astigmatism. The donor quality criteria is less stringent, and there's less astigmatism. Apart from the various things that you actually look at in any case in a preoperative evaluation, such as conjunctiva and cornea, I think the most important thing or most important investigation that you need to do is the pachymetry and the anterior segment OCT, because you need to see at what level the opacity is. So superficial anterior lamellar keratoplasty, I would say, would be, say, even you can go up to 200 microns, but below that is going to be the automated lamellar therapeutic keratoplasty. So manual keratoplasty has a problem because of the irregularity of the surface, because you're doing a manual dissection, which can lead to interface haze, especially over a period of time. And this instrument has completely revolutionized the way we are doing our surgeries now. That is the microkeratome. When you use the microkeratome, it is technically easy, less time consuming. There's a smooth or host donor cornea cut, and thickness is nearly exact with no interface problems. So you can do this technique for all the cases. Probably for this case, you would need to do HALC because it is difficult to cut through the microkeratome, especially if there are areas of thinning. But in all the other cases, ALTK can be done. Now, this is just to show how it is done. So this is a keratoconic cornea where the microkeratome is being used, which is 350, which is going to split the cornea into 350 and 150 microns. So the anterior part is taken, and this is the keratoconic cornea. Again, the recipient bed is dissected, and subsequently one places the donor cornea, which had been previously dissected, onto the host. And because in this case it has gone deeper, so you have to suture it. In case it's superficial, one can just put glue. So there is an interface to it, but important thing is that the interface is quite clear. It is not hazy as in case of manual lamellar keratoplasty. These are some of the results of ALTK in various indications, and you can see the corneas look quite clear. Now this was, of course, SALC, and so I think I'm going to skip that, except that probably I just want to highlight that there are two microkeratomes which are available. One is with the Moria, which I showed you earlier, and this is the one with the Gabor. Both work equally well, but in my experience, ALTK cuts a little more than what is desired, say by 40 to 50 microns, and this cuts a little less than what is desired, again by 40 to 50 microns. And this was a case of, in fact, dystrophy where SALC has been done, and no sutures are put, so you put a bandage contact lens. And I always like to put an inverse kind of a bandage contact lens, because that leads to a better fit. So this is just to show the post-op pictures of the anterior segment OCT. And in cases of ALTK, the fit here is quite snug. Again, sometimes what may happen is that there may be mismatch between the donor cornea and the recipient cornea, so you will have to titrate that part also. And this is again to show in the post-operative period how well the healing at the graft-host junction as well as at the interface occurs with hardly any haze. These are some of the results of ALTK and SALC which have been there available in literature, and again the results are quite good. best corrected visual acuity of 612 or better is seen in 70 to 94% of the cases, and most cases would have astigmatism of less than 4 diopters. We were one of the first to publish our results way back in American Journal of Ophthalmology on various indications of ALTK. Now, this is a publication, a 12-year outcome of microkeratome-assisted anterior lamellar therapeutic keratoplasty, comparison between children and adults, which very clearly shows that there were little more problems with the children as compared to with the adults. Now, this is an elegant paper by Dr. Rajesh Fogla, again, which looked at the state sutureless SALC procedure for Rees-Buckler corneal dystrophy with very good results and no recurrence at all. This does talk about SALC, but this is SALC for anterior corneal stromal opacities after penetrating keratoplasty. Again, it is a reality, especially if you have a anterior haze. And these are our results where we've looked at sutureless anterior lamellar keratoplasty with phacoemulsification, because in these cases, you can have cataract and you may have to even address that. This would be essentially what is called as the hemi-automated lamellar keratoplasty, or HALK, and the studies of this have been published by the SNSE group, where the dissection of the recipient bed is actually done manually because of the irregular surface or corneal thinning, and the donor is cut with the microkeratome. Again, long-term studies, 5-year results with the ALTK, which shows very good results across all parameters, including visual acuity, the spherical aberrations, the cylinder, etc. There can be problems, post-op problems have been reported in some of the cases, like rejection, epithelial defect, myopia, also an infection in one of the grafts. This is again a variant, and I think Dr. Praveen also alluded to this, two-piece mushroom keratoplasty, which is advocated by Dr. Busin, and sutureless superficial anterior lamellar keratoplasty reported in one case in recurrent corneal haze after repeat excimer laser surface ablation. Again, these cases can be very difficult because they have been done, the excimer laser has been done for them, and haze is there, and that has to be tackled. So SALC can be one of the options. Now, it's not a procedure without problems. So this is just to show that you can have perforations. Like I said, sometimes you do gauge, you are cutting what it would also depend a lot on what the pressure is inside your anterior chamber when you are making the cut. If the pressure is too high and the cornea is too steep, then you may have a perforation such as is shown here. Now, at times, what may happen is the recipient is a little bit hazy, and so we do try to do a microkeratome cut here, but we realize that it is still hazy, and you may have to tackle that by doing the dissection manually, and then following which the cornea here, in this case, it is a biosynthetic cornea which is being placed, and subsequently the glue which is being done. So both microkeratome-assisted ALTK and SALC, I think microkeratome is one thing which has revolutionized the way we do lamellar surgery, not only for anterior lamellar keratoplasty, but it has taught us how to do even endothelial keratoplasty, something that we were not doing earlier. It is about the smoothening the surfaces. The intraoperative course is more or less predictable. The postoperative outcomes are optimal, and there are hardly any complications. Thank you very much for your kind attention.